We'd like to welcome Dr. Samuel Daniel, Assistant Chief Gastroenterology and Liver Disease at Mount Sinai St. Luke's and Mount Sinai West for his grand rounds on chronic hepatitis C and CKD patients. Dr. Daniel received his medical degree at Columbia University College of Physicians and Surgeons. He then went on to complete both his residency in internal medicine as well as his fellowship in gastroenterology at St. Luke's Roosevelt. Dr. Daniel has had several different leadership positions in medicine, including previously serving as the president and CEO of the former North General Hospital in Harlem. He has also served as a member of the Governor's Advisory Board on Hepatitis. Dr. Daniel has had extensive clinical experience treating patients with hepatitis C for nearly 30 years. He has throughout his career contributed to literature on hepatitis C, including authoring a book on chronic hepatitis C in African American patient populations. Please join me in giving a warm welcome to Dr. Samuel Daniel.
Thank you very much. This morning, what I'm going to try to do is to talk about a topic that I think is very important to our institution, to the communities that we serve. As you know, there's a high prevalence of chronic hepatitis C in the communities that this system serves. At the same time, there's a high prevalence of chronic kidney disease in patients on dialysis. I want to actually kind of dispel some of the misconceptions that we have about treating patients with chronic hepatitis C who have chronic kidney disease. For many years, these patients were never really given the treatment, mainly because of the drugs that were used at the time, mainly interferon and PEG interferon. But we've come a long way. We've come a long way with the new direct antivirals that have arrived. And I would like to share with you, one, by giving you an overview of chronic hepatitis C and chronic kidney disease and their impact and how they work comorbidly. And at the same time, to give you a historical overview of where we were and where we are today. These are just some of my disclosures. Over the last 3 years, there's been a significant advance in the treatment of hepatitis C in patients who have serious comorbidities such as chronic kidney disease and patients with other medical conditions such as kidney diseases. There are at least two populations of these patients, those with chronic kidney disease who acquire HCV and those with HCV who develop chronic kidney disease. Studies have actually demonstrated that chronic hepatitis C infection can be an independent risk factor for chronic kidney disease. Now, persons infected with hepatitis C can develop kidney disease as a result of extrahepatic manifestations. And there have been several studies showing that patients on chronic hemodialysis have had an increased overall mortality risk if they have chronic HCV. In addition, there are also data showing that chronic HCV may be a risk factor for developing renal cell carcinoma, and that is associated with the acceleration of chronic kidney disease in HIV patients. This condition continues to be one of the most important public health problems facing medicine. It's estimated that approximately 5 million people are unaware of are infected with chronic hepatitis C, and 50% of them are unaware that they are infected. Now, the prevalence of the antibody, which is how we check whether or not a patient has hepatitis C, is approximately 1.6%. But what's really important is the significant morbidity related to the progressive liver disease, the cirrhosis, the hepatocellular carcinoma associated with the failure to diagnose the condition early. Nearly 20,000 patients die annually from the hepatitis C virus. And in 2013, it was shown that 60 other infectious disease, it was higher than 60 other infectious disease in the United States, reported by the CDC. We're talking about diseases such as HIV, tuberculosis, and pneumonia. Now, the prevalence of the virus in the United States is rising, and this is probably because of the tremendous increase in opioid overdoses and opioid use, especially in rural areas, Kentucky, Tennessee. There has been a huge epidemic of opioid use and opioid overdose. But chronic HCV is also one of the leading indications for liver transplantation. But as you know, non-alcoholic steatotic hepatitis is slowly creeping up to take over that role. There are 6 major HCV genotypes, genotype 1 through 6. Genotype 1 happens to be the most common genotype in the world. Now, how do we transmit the infection? Injection drug use has been the most common, and prior to July 1992, it used to be blood transfusion. But notice that chronic hemodialysis also has been associated with the transmission of the virus. Let's talk a little bit about the natural history of the HCV infection. As you see, person gets exposed in the first 4 weeks. They may be infected with the virus, and about 3 months later, the antibody may develop. The patient then develops chronic hepatitis C. About 20% of these patients develop cirrhosis, and then another 4% of these patients, usually we think it'd be higher, but about 4% of these patients annually may develop hepatocellular carcinoma. So as you can see, there's a real complex relationship between this infection and chronic kidney disease. Each of these conditions actually increasing the risk and exacerbation of the burden or the other. Regardless of any other risk factors, HCV infection is independently associated with the development of kidney dysfunction, chronic kidney disease, and end-stage renal disease. You can see this from a recent meta-analysis of approximately 2.8 million individuals, where the HCV infection was associated with a 51% increase in proteinuria and a 43% increase in chronic kidney disease. And the HCV virus and in patients with chronic disease have a 5-year risk of going on to end-stage renal disease, which is 14% higher than the normal general population who develop chronic kidney disease. Now, how does the virus infect patients? And how do they develop chronic kidney disease? It's suggested that chronic cryoglobulinemia may be one of the ways that patients develop chronic renal disease, because it may form an immune complex-mediated glomerulonephritis. It can also go on to a membranous nephropathy. And we know there's an extrahepatic manifestation in terms of patients who develop cirrhosis. They may develop the hepatorenal syndrome. We also have information that the higher the viral load in terms of the burden of the virus in the patient with hepatitis C, the higher the risk of developing end-stage renal disease. Now, prior to universal precaution, dialysis was a significant risk factor for HCV infection. This is probably because of the inadequate sterilization techniques that were associated in patients in these facilities. There was a study conducted between 1990 and 1991 that assessed the incidence and prevalence of antibodies in 499 dialysis patients, and it was shown that the HCV antibody was detected in 10% with a cumulative incidence of infection of about 4.6% over 18 months. So the HCV serology is related to the longer you've been on dialysis. Now, the chronic kidney disease can actually impact the natural history of chronic hepatitis C. In a cohort of about 4,000 patients between 2006 and 2016, patients infected with chronic kidney disease had a significantly higher rate of liver fibrosis and progression than patients without chronic kidney disease. So, among all patients with end-stage liver disease, end-stage renal disease on dialysis, HCV patients have an increased risk of all-cause mortality as well as liver-related morbidity and mortality. It's estimated that the prevalence of chronic HCV among patients in the United States on hemodialysis is about 7.8% to 13%. That's much higher than the general population, which is about 1.6%. So preventing the HCV transmission and the acquisition of HCV infection remains a concern in hemodialysis centers. Between 2008 and 2011, at least 46 new cases of HCV infection resulted from outbreaks in U.S. hemodialysis facilities. Now, conversely, because of the increase in, excuse me, my phone is going off here. Conversely, when you actually have better sterilization techniques, highly trained hemodialysis staff,
Hello? Hello?
you cannot, I have to leave here and go to do procedures at the hospital, so I'm sure that's related. In any case, I want to say when you have highly trained staff, good sterilization techniques, you can actually decrease the transmission of infection in these facilities. Let's turn to the impact of the treatment of hepatitis C. Since we no longer the duration of infection, if we know the longer the duration of the infection, the higher is the risk of chronic kidney disease. We wanted to really make sure that we can manage this infection to prevent patients going on to chronic kidney disease. In a VA study on cirrhosis and other comorbidities contribute significantly to the increased prevalence of chronic kidney disease among patients with chronic HCV infection versus patients without. So for patients with established chronic kidney disease, the comorbid chronic infection worsens outcome. It's clear that HCV accelerates the decline of renal function in patients with stage 4 and 5 chronic kidney disease. It actually increases the mortality in end-stage renal disease who require dialysis, and it actually decreases the graft survival in patients undergoing kidney transplantation. So, the chronic HCV infection is a significant risk factor for poor outcomes in patients with chronic kidney disease. In an analysis of a cohort of about 70,000 patients on dialysis between 1996 and 2015, it showed that the HCV-positive patient had an increased risk of death, hospitalization, and worse quality of life scores. So the HCV infection can actually progress in this cohort of about 1,000 patients with chronic kidney disease between 2006 and 2016. It showed that HCV infection had a significant lower mean time to chronic kidney disease progression than patients without HCV infection, 506 days versus 676 days. So, we have to develop strategies to eradicate this infection because it's essential in minimizing morbidity and mortality. So to achieve this important goal, one has to actually cure the patient in what we call a sustained virological response. A sustained virological response is a patient who's been treated for 12 weeks, and you check that patient 12 weeks later and the virus has been cleared. What are our options? Historically, there have been very few options for safe and effective antiviral therapy for patients with chronic hepatitis C. The standard interferon and peg interferon treatment was limited due to low sustained viral response and poor tolerability of interferon. Over the last 3 years, we have seen the emergence of these new direct-acting interferon-free antiviral medications, which have actually been shown to have high cure rates in most cases with a satisfactory safety profile. This has actually modified the management of HCV infection in chronic kidney disease patients. In patients with GFR lower than 30 and greater than 15, there have been drug regimens that now have led to cure of this infection. It has also changed the landscape of the management of HCV infection in transplant patients. Now, HCV infection is an independent predictor of the graft loss in patients who are transplanted. It has been associated with de novo immune-mediated glomerulonephritis in the graft kidney. So, having direct antiviral treatment now shows promising results in changing this paradigm. Now, if we look at patients with end-stage renal disease with GFR less than 15 on dialysis, we now have data which allows us to use direct antiviral combinations to treat these patients. We're fortunate that this life-threatening viral infection can now be treated and cured in nearly all affected individuals. This, we believe, should lead to HCV becoming a rare disease by 2025. At least that's an opinion. In a 2008 meta-analysis, the treatment with interferon in patients on dialysis resulted in an SVR of about 41%. Treatment discontinuation also occurred in these patients due to poor tolerability of the medication. Interferon therapy also has shown an unfavorable outcome in kidney transplant recipients because of because of low SVR rates and also because of the relapse in the allograft patients, relapse in patients, and an increase in allograft rejection. So interferon is not recommended in patients being treated with transplantation. There's a substantial progress that has been made. We have now drugs designed to block critical steps in the HCV replication. These agents now show SVR rates of nearly 95%. There are about 3 major classes now of these direct antivirals. They seem to occur at the non-structural areas of the ribonucleic acid, where protease inhibitors, which end with the suffix -previr, and complex inhibitors, they usually end with the suffix -asvir, and polymerase inhibitors end with the suffix -buvir. Now, the early antivirals, such as telaprevir and boceprevir, actually revolutionized the treatment of patients with hepatitis C. These patients with normal renal function could have been treated with telaprevir and boceprevir, but they were a poor option for patients with severe renal impairment or end-stage renal disease, because these agents undergo renal clearance, or they required treatment, combination treatment with ribavirin, which is a drug associated with many adverse events, particularly anemia. However, the recent availability of these new direct antiviral combinations has allowed us to actually treat these patients with chronic kidney disease because they are not cleared renally. Now, the second generation direct antiviral, samaprevir and sofosbuvir, actually have changed the treatment of HCV. Sofosbuvir was not approved for use in patients with GFR of less than 30. But recently there have been some reports that suggest that in a small number of patients, or select group of patients, sofosbuvir may be able to be used in these patients. It's mainly eliminated through the body from the kidneys. So there is concern that a full dose of this regimen could lead to drug accumulation and thus adverse drug reaction in these patients. But we saw in a small observational study, it demonstrated that there could be safety given to patients with chronic kidney disease who were being treated with sofosbuvir. In this small study of about 12 patients, 7 patients were given 400 milligrams of sofosbuvir daily in combination with samaprevir, daclacivir, or ribavirin. And another group of patients, 5 patients, were given 400 milligrams 3 times weekly. In that study, it showed that the regimen was well tolerated. No apparent accumulation occurred of sofosbuvir or its inactive metabolites between the dialysis sessions. What was interesting in this study is that there were no relapses in the once daily group as compared to 2 relapses in the 3 times weekly group. So he suggested that sofosbuvir could be used in limited ways in patients with chronic kidney disease, stage 4 and 5. Now, by the 2016, we had now several drugs on the market that did not have to be adjusted because of their renal function. In general, the direct antivirals undergo hepatic metabolism, so there are no recommendations for dose adjustments in these patients. In a recent real-life study to talk about sofosbuvir from Brazil, we looked at the long-term safety of renal patients on sofosbuvir. As I mentioned, sofosbuvir is converted to an inactive metabolite, which is mostly eliminated through the kidney and can accumulate in tissues and biological fluids. In this observational prospective study, patients with chronic HCV were categorized into 2 groups: those with GFR of less than 45 and GFR of greater than 45. The patients received daily doses of sofosbuvir 400 milligram and daclacivir 60 milligram, or samaprevir 150 or ribavirin was added to patients who were considered poor predictors of poor response to treatment. These are usually patients who were cirrhotic or patients who were treated with direct antiviral in the past and relapsed. There were 94 patients submitted to the study, and they were followed from December 2015 to December 2017. These were their mean ages. 70% of them were, 80% of them were female, 60% were genotype 1, and 60% were treatment experienced. These are the difficult to treat patients. 80% were also cirrhotic. 93 of the 94 patients reached a sustained virological response. Now, this is a table of the results, and as you can see, most of the patients were, 80% of them were cirrhotic, and these were the combination used, and they also had similar comorbidities such as diabetes and hypertension. At baseline, 9 patients with chronic HCV renal function less than 45 were compared to patients with mild to moderate renal dysfunction. All the patients with a GFR less than 45 reached SVR. All the patients, 100% of those patients, reached an SVR. Only 3 patients from the GFR less than 45 had their sofosbuvir dose adjusted due to an increase in the serum creatinine levels, and 1 patient had a treatment period reduced from 24 weeks to 12 weeks for the same reason. When you looked at the laboratory data from the analysis, the patients with GFR greater than 45 showed a decrease in their mean baseline serum creatinine. There was an improvement in renal biomarkers also observed. The improvement lasted for a year after the sofosbuvir therapy had been discontinued. So it showed that in the GFR less than 45 patients, there were no significant changes noted in the renal parameters. And at the end of treatment, there was an increase in the long-term follow-up, revealed that there was an increase in the the GFR levels in patients, and that patients were actually decreased a grade in the chronic kidney disease lasting up to a year after treatment. So it was clear that the renal safety and improvement also occurred in decompensated as well as compensated cirrhotic patients in the study. This is a table of the results, and as you can see, the serum creatinine level decreased in these patients and lasted up to a year, and that patients actually had response of up to 80% in terms of their improvement in renal function. So the current antiviral treatment options before the study was done was that patients were going to be treated with umbitacivir, paritaprevir, ritonavir, plus the supervir, a medication called Vicara. This combination is a fixed dose, once-a-day pill taken with the supervir tablet twice daily. This regimen was approved in 2014 after it was shown in a study, which I'll point out to you in a little while. It can be used without ribavirin in patients with chronic hepatitis C genotype 1, with or without compensated cirrhosis. This regimen combination is metabolized by the liver, and there's no dose adjustment in patients with renal disease, except in the patients who receive ribavirin, it has to be dose adjusted because of weight and anemia. This was called the Ruby 1 trial. It evaluated the safety and efficacy of umbitacivir, paritaprevir, and ritonavir, plus the supervir in 20 treatment-naive patients who were non-cirrhotic with genotype 1 infection and had stage 4 chronic kidney disease. 6 of the patients had chronic kidney disease of stage 4, and 14 patients had chronic kidney disease stage 5, or they required hemodialysis. All the patients were treated with a regimen for 12 weeks. The patients with the HCV genotype 1A infection also received ribavirin 200 milligram once daily. After 12 weeks of treatment, 18 of the 20 patients achieved an SVR of 90%. 2 non-SVR patients included 1 patient who died post-treatment, day 14 for reasons unrelated to antiviral therapy, and 1 patient who experienced virological relapse before the 12-week follow-up. What was important in this study is that no clinically significant changes in markers of liver or kidney function were observed in the safety analysis. And the most common adverse event was anemia in 9 patients. None of the patients discontinued treatment. In another study using the classifir with sofosbuvir to treat patients with genotype 1 or genotype 3 hepatitis C infection, it showed that the classifir was well tolerated in HCV uninfected patients with renal impairments. So it became a suitable drug to try in severe renal impairment patients. So As you can see, 12 patients were given the sofosbuvir, and 12 were controls. Each were given a single dose of the daclacivir 60 milligram. Over 4 days, this study was observed for exposure to daclacivir in patients with end-stage renal disease or renal impairment groups, as compared to controls. The findings suggested that daclacivir can be given to those patients with renal impairment, including those with end-stage renal dialysis, without dose adjustment and without the risk of adverse events. However, for achieving rates of SVR of 80 or 90%, a partner-direct antiviral had to be used, such as sofosbuvir, and until the Brazilian study, it was a challenge to really use this drug in patients. Next, I want to point out to you another study using another generation of direct antiviral, grazoprevir and elbasvir. These two medications undergo less than 1% renal excretion. So in the sea surface study, 235 patients were enrolled. 224 patients were randomly assigned to treatment with grazoprevir, elbasvir, and they were going to receive the regimen immediately, or they were given placebo and deferred treatment, 113 of these patients. The remaining 11 patients were started an open-label treatment with grazoprevir, elbasvir, and underwent intensive pharmacokinetic sampling. After 4 weeks of follow-up, patients in the placebo group started treatment with grazoprevir, elbasvir. In the sea surface study, the baseline characteristics were similar in both treatment groups. 81% of the patients had stage 5 chronic kidney disease, and 76% were undergoing dialysis. Most patients with HCV treatment naive, 52% had a genotype 1A infection, and 6% were cirrhotic. They all had common morbidities of cardiovascular disease and diabetes. In the modified full analysis of this population, the grazoprevir, elbasvir treatment arm and its open-label cohort, excluding the 6 subjects for non-virological failure, had a 99.1% SVR after 12 weeks of treatment. This was just an example to show that at 12 weeks that the patients had 100% response. So the results were in line with the phase 3 EDGE study, which is another study done on these patients with grazoprevir, elbasvir, in which 421 patients with HCV genotype 1 and 6 of them genotype 4, and another 6 were genotype 6. 94% of those patients were non-cirrhotic, and 97% of them were cirrhotic, and they achieved SVR of 12 after 12 weeks of treatment. So these findings from the sea surfer trial support the efficacy and safety of grazoprevir plus elbasvir for 12 weeks in patients with chronic HCV genotype 1 infection, stage 4 or 5 chronic kidney disease, including those patients on hemodialysis. Based on these studies, the combination drug Zepatier was actually approved by the FDA in 2016. They also approved it for treatment of patients with genotype 1 and 4, and those patients had to have ribavirin added if the patients were cirrhotic. Now, this is just to show you that if you look at the safety profile, that there was no difference between placebo and the drug in the treatment of patients with chronic kidney disease. So the medication was well tolerated. So by 2016, we now had recommendation from the ASLD and the Infectious Disease Society recommending treatment for all categories of HCV genotypes because in patients with chronic kidney disease, because we now had a regimen that we could use in these patients. So the treatment of HCV infection in patients with dialysis has been shown to be efficacious. Now, how do we treat patients who have, after kidney transplantation? This became a question that one had to answer. Either you had to make a decision to treat before transplantation, or you had to make a decision to treat after transplantation, or you have to consider the extent of the liver damage and make a decision whether or not expedited transplantation was necessary. Now, we also needed to know whether or not the safety profile was in patients with HCV-positive organs, which may be transplanted into HCV-negative recipients. So in 2016, we know that more than 100,000 people in the United States were waiting for a transplant according to the National Kidney Foundation. and that about the wait that could last up to 5 years in certain areas of the country. We also know that in 2014, there were about 17,000 kidney transplants in the United States, and that nearly 5,000 of these people died while waiting for transplantation. You see, traditionally, organs from donors with hepatitis C were only offered to recipients who already had the infection of hepatitis C. So more hepatitis C organs now are available because of the high mortality that we're seeing in patients who are using the opioid overdose in certain parts of the country. So we now have a lot of hepatitis C kidneys available. Therefore, can we transplant hepatitis C kidneys into patients who are hepatitis C negative? It's a question that we have to answer. 10% of kidney transplant recipients in Western countries have chronic hepatitis C. The use of interferon and ribavirin to treat HCV infection in kidney transplant recipients, as I mentioned earlier, is limited because of the risk of allograft rejection and the poor tolerability of interferon and ribavirin. So now we have these direct antivirals that can be given to patients on dialysis, patients with end-stage renal disease. Should we be able to transplant a kidney that's infected into a patient who is negative and then treat that patient at the end of the transplant? So in a study of 20 HCV-infected kidney transplant recipients, a sofosbuvir-based regimen resulted in SVR12 of 100%. In this cohort, 88% had genotype 1, 50% had advanced fibrosis, and 60% had failed a pre-transplant interferon regimen. The sofosbuvir-based regimen included sofosbuvir and samipravir in 9 patients, sofosbuvir-ledaspasvir in 7 patients, sofosbuvir-ribavirin in 3, and sofosbuvir-declaxifir in 1. The treatments were initiated about 888 days after the kidney transplant. In this study, there were no significant changes observed in serum creatinine before or after treatment. Dose reductions due to anemia were required in 2 of the patients receiving ribavirin, and symptomatic anemia occurred in 1 patient required a blood transfusion. No proteinuria or acute graft rejection occurred, and there were no treatment failure. 45% of the patients required dose reduction of the calcineurin inhibitor while receiving the direct antiviral, but there was no correlation apparent in the study of the direct antiviral used. In a similar study of a sofosbuvir direct antiviral resulted in an SVR rate of about 100%. In the study, the patients waited a median of about 14.6 months before the treatment was started after transplantation. There was no drug-to-drug interaction seen with the immunosuppressive agents used. 1 patient required a reduction in their ribavirin dosage, and there was no need for erythropoietin use. But one of the best studies came out of Europe by Colombo. We looked at 5 locations in Europe, and this study was done to evaluate the safety and efficacy of ledaspasvir, sofosbuvir, which you now know as Harvoni, for kidney transplant recipients who were chronic HCV genotype 1 or 4 infected. The study included 114 patients. These were their median ages. 69% of the patients were treatment naive who had received a kidney transplant at least 6 months prior to the study. Most patients were HCV genotype 1, 15% had compensated cirrhosis. All patients had an estimated GFR of about 40. The patients were randomly assigned to receive a fixed dose combination of ledaspasvir, sofosbuvir for 12 weeks. Or they were given ledaspasvir, sofosbuvir for 24 weeks. Now, this study, the patients achieved SVR rates of 96% in all the groups. So now we know that treatment of ledaspasvir, sofosbuvir for 12 to 24 weeks in kidney transplant recipients was well tolerated and seemed to have an acceptably safety profile in patients infected with the HCV genotype 1 or 4. There were adverse events in about 68% of the participants. Only 11% actually experienced a serious adverse event, and fewer than 1% discontinued treatment due to the adverse event. Two of the patients were lost to follow-up. So, when initiating an antiviral therapy in the kidney transplant recipient, the potential for drug-to-drug reaction must be considered. Fortunately, neither sofosbuvir nor the classifir interact with the substrates of these immunosuppressants, so this combination could be one that we could use in these patients. Currently, kidneys from HCV-positive donors are underutilized. The National Registry data from 2005 to 2014 show that organ donation was authorized in 3,273 deceased HCV-positive donors, which represented about 6,546 potential kidney donations. However, only 37% of the kidneys were transplanted. 63% of those kidneys were discarded, despite meeting appropriate quality thresholds. This lost potential is probably more, given that an unknown number of the kidneys were never harvested due to concerns that transplant centers would not accept these organs. In addition, nearly all recipients of kidneys from HCV-infected donors were already HCV-positive prior to transplantation. So the perception that HCV-positive kidney transplantation is therefore changing with the availability of safe and effective antiviral therapy. Now, had the discarded kidneys from the 2005-2014 analysis been used in these patients, we've actually transplanted 4,144 patients. So we now need more clinical trials to really clarify the best practices for using this medication in patients with kidney transplant. Fortunately, there are two studies ongoing, one at the University of Penn and the other at Johns Hopkins. And these two trials are on the way. They're actually transplanting HCV-positive kidneys into HCV-negative recipients, then treat the HCV infection immediately post-transplant. Now, in the University of Penn study, it's called the THINKER trial. It's an open-label, single-group pilot trial in which 10 HCV genotype 1 infected donor kidneys were given to HCV-negative patients. On the third day post-transplantation, all recipients had detectable HCV RNA in their bloodstream. These patients were then given elbasvir, graçapivir, and every recipient was cured of HCV infection at the end of treatment. There's also a study by Rowan colleagues who performed a phase 3 open-label multi-center study. Patients were non-cirrhotics who were treated for at least 3 months after a liver transplant or kidney transplant. These patients had a median GFR of about 62. There were a total of 100 patients enrolled in the study, and they received gacapivir and preventaciravir for 12 weeks. From the data available, 89 of the 90 patients achieved an SVR. This is an incredible result. One patient did not clear the virus. One patient had mild liver transplant rejection, but actually continued with treatment and achieved an SVR. So now we have a 2-drug regimen that can give you up to 99 and 98% response rate in transplanted kidneys. So the future really appears bright for patients with HCV and chronic kidney disease. In 2016, we saw the approval of several new drugs, which have actually closed the remaining gaps in the treatment of chronic hepatitis C. In 2017, we saw the advent of antivirals that targeted all 6 genotypes, with cure rates of 95 to 100%. We also know that the administration of these polymerase inhibitors combined with an NSA5 inhibitor in a once-daily dose regimen, you can actually treat patients only for 8 weeks, rather than 12 to 24 weeks. This was seen in the Expedition 4 trial, which assessed the safety and efficacy of gacapivir and preventaciravir in 104 adults with chronic kidney disease with all genotypes. In the historically speaking, difficult to treat population, these are patients who relapsed after treatment, or patients who had cirrhosis. We saw SVRs of 98%, suggesting that a high efficacy in patients with renal failure. So this regimen could now play a significant role in eradicating HCV infection in patients with advanced chronic kidney disease, especially patients with non-genotype 1 infection. In conclusion, we have revolutionized the treatment of chronic hepatitis C in patients with chronic kidney disease, with high cure rates in the majority of patients, with an excellent patient safety profile. Included in this was the treatment of patients who failed prior direct antiviral treatment and patients with advanced kidney disease. Finally, we can treat patients with end-stage renal disease on dialysis and patients waiting for kidney transplant or after a transplant. And that we know that patients can be transplanted infected kidney in a patient who is not infected with hepatitis C. These patients now have an opportunity to be cured by implementing the current screening guidelines that we have in treating all patients identified with cases of HCV. In fact, we believe that all patients, unless the HCV infection is not going to be the cause of the patient's death, we believe all patients today can be treated for hepatitis C if there's not another condition that's going to cause their demise. So here's an algorithm. Patients have hepatitis C. Patients may either have severe liver disease or mild liver disease. You can decide whether or not you want to treat after the transplant, or you can treat before the transplant, depending on how advanced the fibrosis is. Or you can see the patient and consider treatment right away because of the expedited necessity to treat the transplanted patient. So we now have evidence to show that kidney transplant patients can be given to patients and we can actually improve their graft survival with direct antivirals. And that urine protein to creatinine ratios, when compared before treatment and after treatment, showed significant decrease in proteinuria after transplant. You can actually improve graft function in these patients. And that the drug interaction profile between common immunosuppressants and direct antiviral agents is very tolerable. However, we have to continue to monitor these patients closely. There's still evidence that we need to gather on these patients. Finally, for patients who are candidates for kidney transplantation, treatment after the procedure may be clinically reasonable. In this study, the only interaction occurred was in the clopidogrel-pribentasvir study where cyclosporine showed some drug-to-drug interaction. So these are the drugs we have today. In 2016, we have the NS5As, we have sofosbuvir, velpatasvir, sofosbuvir-ledaspasvir, paritaprevir, and abitavir, ritonavir, the Supravir, and now in 2017 we have Vasefi, which is sofosbuvir, velpatasvir, and voxaprevir, and Mevaret, glopaprevir, and pivensasvir. These are all new drugs that we can treat, and we have as an armamentarium in treating patients with chronic hepatitis C. I'd like to leave you with this. We know, because genotype 1A is the most common genotype that we have in the United States, we now have a slew of drugs that we can use to treat these patients. And some of these patients, the treatment duration is only 8 weeks. The reason why this is so important is because in the early 90s, early 2000s, patients were treated for a year. Patients were treated for 6 months. Now we can treat these patients for 8 weeks, 12 weeks, and in more difficult cases, 24 weeks. And as you can see, this is a patient without cirrhosis, and in a patient with compensated cirrhosis, this is the dose that we can use in the same regimens. These patients are always treated for 12 weeks. I'm going to stop here. Thank you very much. This has been an exciting time for the treatment of patients with chronic hepatitis C. Thank you very much.
Leave some time for some questions. Please.
Thanks for a fine presentation. I'm particularly interested because the Nobel Prize for Baruch Blumberg means a lot to me because I'm from Brooklyn, and that's where he's from. And in a more serious vein, I have a question for you about age. And I'm not talking about old versus young. I'm talking about whether you're aware of any studies about age to help explain the age distribution of HCV. I know the usual explanation is sexual activity at ages 20 and 30, but there could be a biologic difference that makes this virus do better at certain age groups. I mean, worse to the patient, but cause more trouble in younger people than in middle-aged people. Are you aware of any studies that are looking at the biology of aging, not about old people, the biology of aging in HCV?
We have evidence that patients who are older, actually the opposite, the patients who are older did worse with hepatitis C. And as we know, the CDC has actually recommended screening for patients between 1945 and 1965 because these are the patients who are infected. As the patients get older, if they have a higher viral load, we've seen these patients do worse. So the patients who are younger, if we can now treat them earlier, these patients seem to respond much better than the older population.
Great.
So since the treatment is so good, I'm not going to ask a question about treatment, but early on you pointed out that these patients can develop cryoglobulins, they can develop immune complexes, but not everybody who has one also has the other. So is it known which is more deleterious?
Whether or not cryoglobulinemia or versus
Cryoglobulins or versus immune complexes?
I'm not sure we have evidence to show whether or not cryoglobulinemia is worse than immune-mediated. We know that both conditions are playing a role in the patients developing chronic kidney disease. That's why we have to treat these patients.
Please.
I'm just wondering if similar studies have been done in heart and lung transplant patients, and if so, could you comment on those results?
No, I have no information on heart and lung. The only information I have now is on liver and kidney, but I would expect that's coming.
Great. Well, let's thank Dr. Daniel for the discussion.